Good evening, everyone. Welcome to this revision session for our Euro exit exam. I must thank everyone for joining today at short notice. There may be a few more who will like to join in a few minutes' time. So I will talk for about 1 or 2 minutes before I give the podium to Balagobi for his presentation. I just want to tell that after speaking to examiners of this FRCS exam and people who have done the exam before, just like Balagobi, what we realized was there are certain areas that are being repeated always for the Viva session. This is so in any exam. I'm sure you all will remember the part 2 exam, MS or MD surgery. The trauma question, for example, is always there in the theory paper. So similarly, there are some parts which are being repeated and which is there all the time. And in our Uromet sessions, we could not cover all those topics. So what we thought was we will just pick some of those topics. And since Balagobi is very familiar with these things and conversant with the material, to ask him to make a presentation for the benefit of ours. Because if I try to discuss those topics, I will have to study again. It's not easy at this age. So fortunately, Gobi is there for us. And therefore, today's session is just to remind you all about the important topics that you all should know. When you listen to him, you will realize that what you all should know is the true basics for our practicing urologist. We had several meetings with examiners of the FRCS exam, and David Richards, who was the chief person from Glasgow. Some of you must have met him. He comes for the part 2 exam also. He's the man who maintains the quality to ensure that our exam has the standards of the exam of the Glasgow because they award the fellowship from Glasgow College. What he repeatedly said in that session, he spoke for about 20 minutes about the exam. I think within that 20 minutes, he said this word more than 10 or 12 times, that the standards you expect from this exam is the knowledge that a day one consultant urologist in Sri Lanka should have. Day one consultant urologist. That is the knowledge, for example, I had when I went to Gaul in 1999 as the urologist. My first day, the knowledge I had on that day. Not the knowledge that I have now after 20 years. Therefore, you will realize what you need to know is the basics, but you need to know basics very well. For example, how can you do a TURBT safely? How can you do a TURP safely in a person who is on warfarin, who is also having a bladder stone? How are you going to manage? Because that is what you will encounter as the day one consultant. You won't get a very complex case. In such a situation, you can always take an opinion from one of your seniors. Day one consultant will have to do a PCNL, a TURBT, a TURPT, how to bridge the anticoagulants, how to prevent deep vein thrombosis, how will you manage a patient after trust biopsy comes with sepsis, tachycardia, and hypotension. How are you going to manage? How are you going to evaluate a patient for fitness for surgery? Just because a patient is on a catheter, you are not going to do a TURP on him. You will have to assess them objectively, and British people want these objective assessments, performance status. When you do a renal cell cancer and do a nephrectomy, and when the patient comes to the clinic to see the histology, he will ask what is the prognosis. So you should be able to tell that there is this scoring system where we objectively measure your prognosis, and you use the Leibovitz criteria or the calculation, and we say, okay, you have a 70% chance of living for 10 years. So those are the basics that you should know. You have to be thorough with. So don't worry about these complex things, about questions that where there are no answers. Those are of no not relevance to this exam. So I just want to tell this to encourage you all, because what I noticed during our mock vivas was that I think most of you had enough knowledge to have the pass marks. There are a few gaps in your basics, uh, but some of you didn't get the required mark, probably because the examiners were expected the knowledge of an experienced urologist, not of a day one consultant. But for this exam, it will be day one consultant, and all the questions that will be asked will be prepared by the examiners of Glasgow College, not by us. We don't know what the questions are. The questions will be shown only on that day. The examiners will be from Sri Lanka, but they will be just like puppets. They will just look at the piece of paper and ask the question. That's all they will do. Even a SR can do that actually. So we will not have any opportunity to ask what we want. So don't worry, all the basics will be asked, which are important for a day one consultant urologist in Sri Lanka. That's the point I want to stress today. So without talking too much, I will ask Balagobi, who has been very helpful. Actually, I wouldn't have accepted this whole project if not for him. And Nishanta was also there, but unfortunately he decided to sit for the exam, so I lost him. But I'm always grateful to Balagobi for doing all this work, strenuous work, taking off this time and spending his leisure time on behalf of all of us. To me, of course, it had been a learning experience, so I have benefited a lot. But Balagobi has done a tremendous job for all of us. I will not get a chance to speak to you all before the exam. That's why I'm telling you all these things. Therefore, I'm always grateful and truly appreciate what you have done, Gobi, and I give you the opportunity now to make your presentation and to ensure that all our candidates will pass this exam. Thank you.
Thank you, sir. Now, can I see my slides?
Yes.
Yeah, okay. So before starting
not the slide presentation, Gobi, if you can put that slide presentation, it will be better, but still we can see it.
Okay, so maybe the same issue, so I don't know. Okay,
yeah.
Can you see this slide now? Yeah. So the point I want to say here, sir, that there is a small difference that what we have done up to now. So we were discussing 10 minutes each for each scenario, but in the real exam it will be 7.5 minutes each. So they have recently changed because of the new exam system and the COVID and situation. So they have reduced the one station timing.
Okay.
So we have clarified with the Firas sir and Ajit sir and Lesko. So that is their time. So we can't do anything about the timing.
That's right. True.
So so what we have to be careful is don't talk a lot of unnecessary things, especially the first few questions.
True.
Progression is very important, especially if they ask about assessment. Important points. Don't talk just because you know a lot. Don't talk much on that topic, because as I said earlier, more complex the question, more marks you will get, because they want to assess in the final question how will you handle the difficult situations. There may be some question without any answer, and how you handle that kind of situation. So my humble request is, time is 7.5 minutes, is go very quickly. Of course, they might have made some adjustment in questions. They have reduced the kind of open questions. So they will ask more closed question, structured. So you will have a 2 or 3 word answer rather than a lot talking. So precise with your answer. And there will be 8 stations. Between 2 stations, you will get about 5 minutes of break. And there will be a 1 station that is a rest station. So you will get about 15 minutes. So you can relax and you can work for the next station. So half of the candidate will come in the morning I think till 11. So you got the timetable. So half will be, you had started 7, another half will start at 11. So just only different up to now we have discussed is the time. So just remember it's not 10 minutes, 7.5 minutes. So you had to progress fast. That's the point I want to say this. Then I will move to the more frequently. Of course, we have discussed a lot about other things. So the first things they will ask is any. Can you see my next presentation?
No, Gobi.
Okay, yeah.
It came as that you're going to share. Yeah, can see. Yes.
Right. Can you see the full version, sir? Or
not the full version, but we can see the slide.
Right.
Fairly good.
Right. Okay. So I will make it like this. Right. So this, of course, performance status. We have discussed this in detail in MD exam, in our MD part 2. The WHO or ECOG or WHO from 0 to 5. 5 is a dead patient, 0 is a normal patient. So whenever you are saying any decision making, just mention I will assess the performance WHO, because I have not seen that they are using the ECOG word. They use a WHO word, WHO performance score, and I will decide the management depending on the performance score. So they are not using much about the Karnofsky scale. So they use the WHO scoring. That's for a performance score. They are not much interested about this one, Charlson Comorbidity Index, CCI. But better to know if they ask, okay, any other methods of assessing, you can say Charlson Comorbidity Index. Let's have a lot of diseases with different score, with the mild diseases 1 and severe diseases like metastatic diseases, so 8, 6. So depending on diseases, they calculate a score. Then they decide about prognosis. But we don't need to remember this. Just remember this name, Charlson Comorbidity Index. That is a bit new for us. Then the another one very important that is mentioned in the EAU guideline also, G8 questionnaire. But G8 is a geriatric patients. They ask 8 questions. So G8 questionnaire in the EAU guideline, I think is under the either bladder cancer or prostate cancer. This is given. So there are 8 questions. So they assess the get a score. Depending on the score, they label as fit patient, frail patient, and unfit patient kind of classification. Again, just know this name, G8 questionnaire. They might ask, okay, if a geriatric patient come, anything special you have to assess the fitness, you can say, I can use the G8 question. You don't need to remember this. These are all questionnaires. So, you know, so don't need to remember everything. You can just remember there are 8 questions like age and comorbidities and what how many drugs they are on and kind of things, right? That's a basic. So there are more, but you can't remember everything. Just remember WHO status, performance status, CCI, and GI. Dr. Nishant, anything else regarding the performance status? Anything new?
I think maybe the Charlson Comorbidity Index is mainly used in renal cell cancer and the the metastatic renal cell cancer and the Karnofsky performance score. That is where they most of the time they use it, because the management guidelines are based on some of these performance scores. So I think at that point there is a possibility that they might sort of ask.
Okay, yeah. So this is regarding the performance status. And the next one, the cardiac risk evaluation for non-cardiac surgery, again a hot topic. just remember the ECG or echo is not going to decide the fitness of the patient, because echo is done when the patient is just in the supine position, sleeping position. The most important assessment is a stress. You have to give a stress to the heart and assess. Of course, in the history, we can assess the MET score. So we have studied about MET score in MD, metabolic equivalence MET score. So depending on the exercise, how many steps they can climb. So, MET score. So you had to know about the MET score. That's in the history. Next important thing is if a patient having a good MET score, performance score is good, we don't need to assess the detailed assessment of the heart. But if the MET score is less than 4, then we have to do a detailed cardiac stress test. So they will ask what kind of tests we have, exercise ECG, induce the heart with the dopamine, induce a stress in the heart and doing the echo, stress echo. And sometimes we have to do a angio, either CT angio or the conventional angio. So that we have to mention. Just remember cardiac risk evaluation for non-cardiac surgery, not just ECG and echo. You have to give a stress to the heart and assess. One is the history and examination, other one is investigation, that like a stress exercise ECG or stress echo with the dopamine. Anything else, Dr. Nishanda, regarding this cardiac evaluation? Or Taha, or anyone you can give the input. Dr. Nishanda, Dr. Taha?
Yeah, I think that's all. I also think so, Gobi.
Yeah.
I don't know whether there are any validated tools, or is it just to just to mention the steps like the echoes, and
I
then
think there is another one. I don't know how important is the Duke activity status index. That's the 6 minutes walking test, and the simple stair climbing in the history we ask. I don't know whether it is relevant.
Yeah. Okay. So maybe there are something you can mention, but MET score and stress thing, and just see the EA guideline or NICE guide, anything else they are mentioning, but these are the few things they ask. Yeah. So then, of course, that day I discussed in a detail the sepsis. There's a lot of change in the definitions. Anyone, they will somehow clarify this theory in a critical emergency or in infection. They will ask this just to see whether that sepsis management and sepsis definitions are changing now, because sepsis definition is life-threatening organ dysfunction due to infection causing inappropriate the inappropriate host response to infection. Life-threatening organ dysfunction due to inappropriate host response to the infection. So they are just blaming the host rather than the infection. So they are saying that's a new change, the sepsis definition. Again, there's another definition: infection plus SOFA score 2 or more. That's another definition. Infection plus SOFA score 2 or more. That's another definition for sepsis. Now, then we have septic shock. So there are definitions like severe sepsis, and those are not they are using now. And they are SIRS, they are not using now. So you know what is septic shock, where we are giving the adequate fluid and patient is not improving, and the mean arterial pressure is less than 65. So you had to give a inotrope, so vasopressor. So in septic shock, you had to give noradrenaline. Cardiogenic shock, you give the dopamine. Anaphylactic shock, you give adrenaline. So they might ask about a little bit about anaphylactic shock. Okay, you are doing a CT scan, but what you give, what is the risk of anaphylactic shock after giving contrast? How will you manage the anaphylactic shock? One of question they can ask just to check. Yeah, we know that. And also sepsis 6, I have told that day, giving 3, taking 3, remember it. And the new concept about surviving sepsis campaign and 1 hour bundle, 6 hour bundle, we all know. So just know about this is all theory, but they will ask, they will make questions, and they will check whether you are updated about sepsis. Anything else, Taha, Dr. Nishanda, anything else regarding sepsis you want to update?
I think the definition change is what is there in the new EAU guideline. So sepsis now currently the sepsis, we all have been trained on sepsis version. From 2016, it is sepsis 3 version. So the definitions has changed and they have more simplified, as Gobi rightly said. Then I think. Yeah, I think we need to, I mean, if anybody is interested, I'll just run a couple of slides because I have just did one presentation today.
Okay, so
yeah,
I will stop this. Yeah.
Yeah. Can you all see? I don't know.
Yeah, we can see.
Okay. So I think the concept what Gobi said is the localized infection versus sepsis. So sepsis is just a localized, infection is just a localized phenomena, and the sepsis is more of the localization has failed, and the sort of cytokine storm has had a widespread effect on the endothelial level of every organ, and that will lead to organ dysfunction. So that is basically what is sepsis syndrome. So it's just not just a one organ, has multiple organs. So the definitions, as Govi said, the sepsis new definition is life-threatening organ dysfunction, which is caused by dysregulated host response to infection. So those are the keywords. I think if any chance we had to remember that one, organ dysfunction and a dysregulated host response to infection. Those are the two keywords. Then I think the septic shock definition, again, basically a profound circulatory inadequacy in the absence of hypovolemia. And then the mean arterial pressure. There are two more important components that you need to mention. The MAP is less than 65 and the lactate levels are more than 2. So I think that has to be included in the definition. This is what is given in the EAU guidelines also, the new one. So the iterations, what we are running now is the sepsis 3 iteration. So which is actually more simplified. Earlier, you had to see that we all did this, like acute inflammation, SIRS, and then modes and sepsis, organ dysfunction, and severe sepsis to shock. So now it's more simpler. It is infection plus organ failure, which is called sepsis. And refractory hypertension and hyperlactitemia is what is called shock. So that's the difference. And of course, the management-wise, the 4 key concepts of prompt recognition, early goal-directed therapy, and source control, and adjunctive treatment, which we just Gobi mentioned. Again, this I think this is important in starting off any statement or when you talk about the management. So the suspicion of sepsis. So as we all know that the sepsis is organ dysfunction plus infection. So organ dysfunction, how do you assess organ dysfunction? It is by QSO-FASTO. So that is very simplified and very easy now. So it is tachypnea, altered mentation, and hypotension. So if 2 of these things are there, you had to suspect organ dysfunction. And then how do you assess infection? Again, clinical, and then markers, and also the imaging. So if you have all these clinical details and radiological details, you can establish infection, and that equals sepsis. So it's very more of a simplified way of assessing sepsis and diagnosis sepsis. And as you said, once you diagnose, there's a 1 hour protocol that is called sepsis 6. Within 1 hour, we need to do this. So take 3 and give 3, and also discuss the intensivist during that 1 hour. You might have to know a few of the local guidelines, because they might ask you what antibiotics would you prefer. So in the local guideline, what is given is ceftriaxone or 3rd generation cephalosporin plus or minus gentamicin. That is plus or minus. So if you think, especially all these are uropathogenic E. coli most of the time, so gentamicin addition is helpful. But if it is a post-operative patient, like post-URS or something, the first line of choice is meropenem. And again, plus or minus gentamicin. But if you suspect Fournier's or emphysematous pyelonephritis, you can add some anaerobic cover, so which includes metronidazole. So that is the local guideline. I think that is important to know the local guideline also. And of course, the source control, we all know this, and the supportive and adjunctive treatment, which includes vasopressors and hydrocortisone, glycemic control, stress ulcer prophylaxis, and enteral nutrition. And this is the 6 hour goal. So 1 hour we'll have to complete the sepsis 6. At the end of 6 hours, these are the parameters: MAP, urine output, central venous pressure, lactate, and oxygen, venous oxygen saturation. These goals has to be achieved within 6 hours. If you achieve this, the literature shows greatly improved survival. So that's the advantage. And your aim is to prevent the organ dysfunction. How do you do that? By improving the perfusion and improving the oxygenation. So that's that's a summary of it. I'll stop it from here, Gopi.
Yeah, so so 2 more points I want to say here. Now, one is you said about, and when you are talking about infection, you said about local protocol. So please just use that word. We will give the antibiotic. Can you see my slide?
Yes, we can see.
Yeah. So please use the word. We will treat the according to the local protocol, but I prefer these are the 2 antibiotic or something like that. That's the one important thing. The next thing, regarding the examiners, like our vivas, they won't shake the heads. They won't say good, good, good. Those things, they won't do it because they will, in a TOT they have on Monday, they will tell that, please don't show any emotions in the face. So it is difficult actually, you don't know whether you are telling the correct answer or wrong answer. So in our exam, most of the time, the examiners, show some emotion in the face. So they strictly follow not to show any emotion, because that might affect the candidate's performance. That is the argument. So just careful. So if the examiner is not showing any emotion, don't think that you are giving a wrong answer. Yeah, that's the one more thing I want to say. Right. Okay. So sepsis, very important, and the performance scores, very important. So next thing is regarding anticoagulation and DVT, because they are part of the world. DVT is very common problem, not like here. So they will ask, how will you assess the risk of developing DVT? And they will ask, okay, patient is coming for surgery, and most of them, 80s and 90s, almost everyone on anticoagulation. Everyone have atrial fibrillation. So how are you going to bridge it? So we have studied this in MD part, so we know that we have to stop in 5 days before. Then we have to assess the risk of thrombosis, and depending on the risk, and you have to liaise with the hematologist and a cardiologist, and you start the heparin. So depending on what heparin you are going to start, the timing you stop will differ, and you will know about antidote for a conventional heparin, and the problem with the low molecular weight heparin. Those things you have to know. Then the thing we don't know is there are lots of oral anticoagulants. We only know warfarin. So last few years, there's so many oral anticoagulant schemes. You know, all over the world, you will see this. Everyone is on apixaban, edoxaban. How they act? Most of the time, they act in the common pathway of the clotting system. Prevent the factor 10 become factor 10A. So just see, because they might ask, do you know any newer version of oral anticoagulants? Now, of course, they are not new, but we have to know about oral anticoagulations, how they act, how they differ from warfarin. So warfarin inhibit, that's vitamin K pathway, but this is different. Just read about this bit about anticoagulations. Anything, Dr. Nishant or Taha, regarding anticoagulation and urology and DVT and urology? Anything else you want to tell?
I just wanted to ask you, but the hematology referral or cardiology referral, when a patient comes with the, when the patient is on anticoagulants, do we really have to do it all the time, or we just have to do it only for the high-risk patients?
So they have to tell whether, so risk stratification, they have to decide depending on is a prosthetic valve or is it what kind of valve they have, and the risk assessment, of course, cardiologists have to tell. So always better to discuss with them and decide. If they say low risk of clots like atrial fibrillation, they take it as a depending on the previous incidents of fibrillation and things, they decide whether it's a low risk or high risk. I can't exactly remember. So there are disease, they are low risk, of course, no need of bridging. So that we have to read around that anticoagulation.
Yeah, sure.
Right. So then, of course, they are going to give a lot of imagings. We know this is a very basic. So just use the word, this is a coronal section, this is a sagittal section, this is axial section. That body plane, we have to use that word. But also, there are a few other words you have to use. If they give just X-ray, that is less likely. Something white is a radio-opaque. Something black, radiolucent. They give an ultrasound image, something white, you say hyperechoic. Black is hypoechoic. CT, white, hyperdense, density. Black, hypodense. MRI, they say you can say high signal or hyper signal area, white, especially MRI prostate. You can say there is a usually cancers are in T2 hyposignal, black areas. In the periphery, I can see a hyposignal area in this T2 image at the right peripheral zone. So I think it may be a malignancy. So I want to see the other images like ADC map and things. You know, you have to talk like that. So that's wording, hypersignal, hyposignal, or hyperintensity, hypointensity. That's wording should be there for MRI scan. A nuclear scan like bone scan or PET scan, if you see anything black, you have to say hotspot, or you can say high uptake seen in the L2 vertebra. So, or hotspot is seen in the L2 vertebra. And they might ask, what are the other possibilities? It may be a metastasis, it may be a recent fracture. It may be, infection or arthritis or something. So use the word high uptake and lower uptake or hotspot. So these words, if you use it, it will be nice when we are when we are describing the images. So 5 images and 10 different words. So that's anything else? Anyone, Dr. Nishant, you want to talk about this terminology when we are describing? And anyone know what you understand by super scan in the bone scan? They use that word. Super scan, Dr. Taha, do you know what is super scan in the bone scan?
Super scan is multiple metastasis.
Yeah, so all over the body
All
there
over
is
the
so
body.
many bits. So maybe you won't see any radioisotope in the bladder. You know, usually you see some radioisotope in the bladder, but here the isotope goes all goes to the cancers. So super scan, right? So that terminology, we all know this terminology. So better to use these terms. It will be nice and professional, right? Then, of course, they will ask about the stages, the contrast CT scan, different stages of the contrast CT scan. So, regards to the kidney, arterial phase, around 30 seconds, portal venous phase, around 60 seconds, but times can change, 60 seconds, depending on what type of CT machine you have, how many slices and things. And then portal venous phase, then it goes to the kidney parenchyma phase around 90 seconds. I just remember 30, 90, 30, 60, 90, but it can change. Then delayed phase, just remember that minutes, 10 minutes delayed phase. Usually, classically 10 minutes, they will take the X-ray, CT scan. That's why, in a trauma patient, they will ask this question, okay, can I ask Taha? So you are doing a trauma patient and you have a doubt after opening the abdomen, you have a doubt whether you have not explored the ureter yet, but you have a doubt whether there is a ureteric injury and leakage of contrast. So you want to confirm that on table. So what am I going to do now?
So in the intraoperative, I can do a single shot IVU. That is 2 milliliter per kg IV contrast, and I will do a single X-ray in 10 minutes.
Yeah, that's a point I want to say. So you have to wait about 10 minutes and use a C-arm and take a picture. Then you will see the contrast. If a contrast is going nicely into the bladder, so then you know that unlike the ureteric injury. So this kind of question they will ask. So just remember that 10 minutes, delayed images are 10 minutes, and they will ask the dose of the contrast you will give, and they will ask what type of contrast you will give. I will come to that point later, right? So stages of contrast scan. And the other point they will ask is regarding this radiation dose. Very important, radiation dose. Now, whenever you are explaining to the mother or of the child or a patient, you have to talk about the radiation dose the patient is exposed. So radiation dose, the unit is, just remember the word millisievert, MSV, millisievert. 1 millisievert mean if you are living in a earth per year, you are exposed to the radiation from the earth. The whole year, the radiation exposed for the 1 year is a 1 millisievert. But non-contrast CTKUB, how much of MSV is? Around 3 non-contrast. Just X-ray, like chest X-ray, is a 0.1. So that's why we say contrast CT scan or CT urogram is 10 millisievert. So just remember common MSVs, 10 NCCT-KUB and chest X-ray, because then you are explaining how, okay, what's the radiation dose. This they will ask. So these pictures are in our FRCS Viva book also. So when you are explaining this to the patient, you have to say, you have a 3 millisievert. That's mean if you are living in the earth for 3 years, you are exposed to the this kind of radiation. So then patient will be all right. So, they don't know what is the dose, I think. And they might ask, okay, if anything in less radiation in NCCT-KUB, then you can say low dose NCCT-KUB. If your stone is in the distal ureter, you can just do it in the pelvic NCCT-KUB. That kind of things they can ask. So to compare the radiation exposure, they will you have to know this the effective dose. That's the word they use. Effective radiation dose that measured in MSV. So just remember that annual radiation dose considered normal annual radiation dose is 2.5. Yeah, naturally 2.5. So NCCT kV also more or less same. So just remember that radiation dose. Yeah, so 2.5, 2.3 is the annual background radiation per year. Yeah, okay. So anything else up to now regarding the phases of contrast CT scan and regarding the radiation exposure? You know that radiologists have a what's that? There's a small meter they have carry all the time, so that will measure the MSV. Yes, Dr. Nishantan.
So dosimeter or
Dosimeter, yeah.
Yeah, I think, Gobi, I think the two, it's important to clarify the two sort of parameters. One is the biological effective radiation dose, which is just the radiation dose which will give rise some biological effects. That's how they measure the exposure of the radiation. And then the dose delivered is just the dose, standard dose delivered, which is calculated by the radiation oncologist, and that is given in gray. And
Yeah.
as you said, the biological effective dose, where I can cause biological effects, is measured by millisieverts.
Yeah. So 1 gray is equal absorption of 1 joule of energy. So if you take prostate cancer, we will give about 70 gray, 74 gray. So that's a gray. So that's a dose delivery. Okay. Then yeah, they are interested about this one regarding contrast. So almost, you know, ionic contrast, non-ionic contrast, isomol, hyposmolar, low osmolar. So so this is very important, right? So so more side effects with ionic and high osmolar contrast. So the isosmolar is visipaque. The name, just remember, visipaque, and the low osmolar is omnipaque. Those are commonly used contrast. So they might ask you what all contrasts are made of. I will show you that picture. I will come to that. So so high osmolar, low osmolar. So we like isosmolar or low osmolar non-ionic contrast. Okay, so less side effects. So all the contrasts have same structure like this: a benzene ring, tri-iodinated benzene ring. All the contrasts have 3 iodine with the benzene ring. So depending on the side chain in the position 1, it's all changed, whether it is ionic or non-ionic or what kind of contrast change. So they might ask you about this basic about this contrast. So please read around these types of contrast. Yeah, any input, Dr. Nishanda or Dr. Ta, any input about this?
No, Gobi, I think.
Right, okay. So then in a technology station, they will ask about ultrasound scan. So we know everything about ultrasound scan. It's a high frequency sound. The few things we have to remember, so more frequency, you get a clear picture. But more frequency, the depth of infiltration will be less. For example, for abdominal ultrasound scan, usually we use the 5 megahertz ultrasound scan probe. So everything is decided by this probe. They are the expensive one. Now in a scrotum or thyroid or vascular scan, we need a high frequency because we want to get a good pictures, but less depth infiltration. So they use about 7 or 10 megahertz probes. So just remember, more increased frequency, you get good resolution, but decrease penetration. When you say duplex, you are combining conventional ultrasound scan with the Doppler effect. So that is a double function, duplex scan. So that words, you know, right? So, and bone is, when you have bone, ultrasound is not good. When you have a water fluid, is good. That's why always we send the patient with full bladder. For the gallbladder, they will send with the fasting. So the gallbladder will be full. So they might ask you, okay, the price of ultrasound machine is depending on what? Is depending on your probes. More probes you request is expensive. So what kind of frequency used for your trust biopsy? Of course, it's high frequency. So, 7.5 or 10. So if you are going to do a urology ultrasound scan, you need an abdominal probe, you need a scrotal probe, and you need a transrectal probe. So at least you have to request for a 3 probe. And the shape of the probes also different. One will curvilinear, linear, different shape. Okay, so basics knowledge about ultrasound scan machine and the probes and the frequency. That's important. So they might ask you, especially they are concerned about transrectal ultrasound scan probes. So how they work, ultrasound scan, the sound waves emitted, and the amount of sound waves reflected will be received by this receiver. So this is act as a emitter and receiver, dual function, right? So that is about ultrasound. So there's more about, but just basics, you have to know about ultrasound scan. Then CT scan, we all know attenuation, the word attenuation, or enhancement. Enhancement, that's a word that is measured by Hounsfield unit, right? So bone will be 1000 plus 1000, air will be minus 1000. So if you see a dark black stuff in the CT scan, inside the kidney, dark black, means air in the, so don't say gas. They like this word air. I don't know why. So there is air in the kidney. So I think it may more likely maybe impassive pyelonephritis or post-procedure, or maybe a fistula between bowel and the kidney. So that kind of answer you had to talk. So AR 9,000 minus 1,000 plus 1,000, and the tumors will be around this, gray color things like plus 30, plus 20. Fat will be minus 50. So so just remember this Hounsfield units, and bone, air, and 0. That's water and other things, right? So CT scan. MRI scan, we all know T1. In T1, so in T2, bright is any water containing stuff will be bright. So H2O, just remember H2O. Water containing stuff will be bright or white in the T2. That's mean how will you check that? You see the bladder, there will be white stuff, urine. Or if you can't see the bladder, then you see the spinal cord. You might see the CSF, white color. So white stuff will be in T2. But the thing is, in T1, fat will be white and the water will be kind of black. So that's a difference. You had to know T1 and T2. And if you are giving gadolinium, then you get additional images, right? So the basic about MRI scan. They might ask you how it work, and you had talk about protons. They come to the one line, and when they suddenly stop the magnetic wave, they go back to their normal orbit. They release the gamma radiation and things. You had to talk how the MRI scan work, and you had to know about absolute contraindication for MRI scan, like metals inside, claustrophobia, extreme obesity. Then they might ask, okay, someone have a claustrophobia, but you want to do a MRI scan, what you can do. Any answer, Taha? So someone, of course, in our country, it's not possible. I'm just asking you. Patient having a severe claustrophobia, and you suspect the prostate cancer, and you won't do MRI scan. But what you can do, Taha? Any idea?
Sedation.
Okay, so you can give sedation and do it. Yeah, a patient doesn't like anesthesia, for the MRI scan. Anything obvious? Anything easy things?
G.
There are open
Chloride.
MRI.
Okay.
There are open MRI, but of course, the quality of images will be poor. So that's the answer you have to say. So someone come with the severe obesity, you can't put in them inside. Then, of course, again in our country we can't do anything. But someone coming with the massive, morbid obesity, and you want to do MRI scan, but you can't put in the MRI machine. What you can do? Anyone? Or what they do in other countries? Again, they send to the veterinary hospital where they sometimes do MRI for elephants and things. So they use that MRI machine. So they can just check whether you know this thing. But all the things are available, and we have done those things. So I'm just asking this. But of course, in our setup we can't do this, right? So and they will ask, okay, if you're going to request an MRI scan for your hospital, and they have put you in an expert panel, which MRI machine you are going to request. They're asking you want a 1.5 or 3 Tesla. So which one you will go for? Obviously, you will go for a 3 Tesla. Do you think in MRI, the pilots grading, this Tesla make a big difference? Of course, in the pilots grading, it's not making big difference, but of course, 3 Tesla is more clear picture. Then they can ask about problem with the gadolinium. We all know about the problem with the gadolinium, especially if EGFR is less than 30. If you give gadolinium, they will develop NSF. So nephrogenic systemic fibrosis. There are not of cases, but about 300-400 cases. So they will develop fibrosis everywhere in the body, mainly under the skin and over the joints. They will develop. So I have seen one patient develop NSF, and the patient came and even the Prime Minister met and gave the compensation, and they have written the case report, and they have included the patient name also as a co-author. So it happens gadolinium. So we have to know what are the contraindication, VEGFR less than 30. So they can talk about that. Then everything about DTPA, DMSA, MAC3, we all know that. So I'm not going to detail, but just know what's the difference. The DMSA, it's by absorption, tubular absorption. So that is good to see scarring and thing, DMSA. So it's not depending on the EGFR. But DTPA is a glomerular filtration. So you can measure the split function. So DTP is not good. Someone have EGFR of 15. It's not good because it's glomerular filtration. So no point of doing DTPA in end-stage renal failure. Then you have to go for a DMSA. MAC3 is different. MAC3 by tubular secretion. So it's not depending on the glomerular filtration. MAC3 is good even for a poorly functioning kidneys. So those kind of questions we have to know the different scans. So MAC3 is now available in LRH. So we all know that. So and to see the obstruction is different. To see the split function is different. To see the morphology, DMSA is good. So to exactly calculate, and this question they have asked from me, what are the different methods they are to measure the GFR? There's a lot of method, but unfortunately I couldn't remember a lot. One method is you can use that formula, and they asked me what is the formula. Again, that formula, all the white people know that formula, but I couldn't remember that. It's a big formula. I just remember, I don't know, there's a formula for EGFR, depending on the weight and height and things. So just serum creatinine. GFR calculation formula. There's a formula, one thing. So that is a estimated E. You estimate it. Whether you're black or white, there's a different. There's a number 1.2, multiplication number is different. So that's the estimation of GFR. So then other one is a EDTA. Like it's a EDTA we can use, like inulin and things, we can use EDTA. But the best method is to see the exact glomerular filtration of each kidney. The DTPA is good. So there must be more. They asked this question from me in the exam. What are the different methods? We can measure the glomerular filtration rate. At least a few. Okay. So yeah, so glomerular filtration, DTPA more than 90% by glomerular filtration. But MEC3 more than 90% by tubular secretion. So they are different, right? So and DMSA by tubular absorption or tubular fixation. So you have to remember, they will ask this, okay, these three radio traces, how they act, right? So you all know that radioisotope, the isotope is different. Most of the time, isotope is a technetium 99 because that's an easily available isotope. They will ask about this also. Why you like technetium 99, not other isotope? Because technetium 99 have a long T-half. And how they come, you know, of course, if in case of Sri Lanka, we are getting from India. So you have to, you know, plan this thing quickly because they will decay and disappear. But there is a, what is it called? I can't remember. I know that name. So if you have that, they have in Magaragam, I don't know. You can create the technetium 99. Anyone know that how we can create the isotope locally?
It's called cyclotron, Govi, isn't it?
Yeah. What was that?
Cyclotron, yeah.
Cyclotron, yeah. So we have in Maharagama one, is it?
Molybdenum, they can use various other molecules.
Yeah, so cyclotron, yeah. So they asked that question from me. So how you can, yeah, that's the question they asked. And you see, most of the time we use technetium 99. And so that is the isotope. The DTPA, DMSA, MEC3, all are radiopharmaceutical. They are specific for the organs. So like, you know, DTPA, MEC3. So in a liver and thyroid, we use a different thing. Thyroid, we use iodine because iodine goes to the thyroid. Those are radiopharmaceutical and radioisotope. So they also combined. They're tagged. You're tagging the pharmaceutical to the isotope. So read around that. So they will definitely going to ask you about this. So these are not difficult. We have studied this in MD also, right? So up to now, anything, Dr. Nishana, you want to give update?
I think you explained everything. Yeah.
Right, okay. Then the PET scan, they will ask, what is FDG PET? We all know FDG PET. Why we can't use the FDG PET in the prostate cancer? Why we are using the colon PET? And what PET scan, what PET CT scan? What is the advantage of PET CT over the PET scan? And what is different in the PSMA PET? Taha, can you tell me what is FDG PET? In a renal cancer, bladder cancer, we use FDG PET.
Yeah, because it is excreted by the kidney and accumulates in the bladder. So that
what
is
does
why
FDG stand for?
Fluorodeoxyglucose.
So it's a glucose.
Yeah.
Right. So glucose is a, you know, will be absorbed by any cancer cells. More aggressive the cancer cell, it uses more glucose. It will be transported by glut transporter. Now, all these cancer, like renal cancer, bladder cancer, they are, of course, I will come to that. Bladder cancer, we are not renal cancer. Renal cancer, FDG PET is used. Why in bladder cancer, we are not favoring much about FDG PET? You told the answer, I think.
Yeah, because it is excreted and accumulated in the urinary tract.
Yeah, it will be in the bladder, so you can't see which is a cancer or, you know, it will be the pelvis. You know, FDG will excrete and comes in the pelvis, so you can't differentiate. Right? Okay. Why we can't use the FDG PET in the prostate cancer? We use the colon PET. Yeah, Dr. Nishanda.
I think it's for the same reason of close vicinity of the bladder and the prostate. And I think there is accumulation in the adenoma also, is it right?
Now tell me, prostate cancer is metabolically active cancer or metabolically inactive, slow-growing cancer?
Yeah, it's more of a slow.
Yeah. So FDG is not useful because it won't uptake a lot of glucose.
Yes.
So that's why we are using the choline. Right. So Right. So choline, fluorine. So all these things is different from FDG. Yeah. So now, what is the advantage of PET-CT over the PET scan?
Because in the PET scan, there may be false positive result due to inflammation also, where the uptake is high. So if we combine with PET-CT, we can differentiate that from an inflammation or malignancy.
Dr. Nishanta?
I think the PET-CT is just a positron emission and a gamma radiation, but we can't anatomically define the exact spots. So if you want to get more anatomy.
Yeah. So answer is PET-CT is a functional imaging. CT scan is an anatomical imaging. You just get the PET-CT, you won't get a much anatomical. You can't localize where this hotspot. So when you combine both the functional imaging and anatomical imaging, you get a clear picture. You can exactly say where this hotspot. That's the advantage of PET-CT. So yeah, then the next point is PSMA PET. That was popular from 2019. So tell me, Taha, what kind of situation you will use PSMA PET in the prostate cancer?
Where the biochemical recurrence we suspect and the PSA is less than 0.1, we can use PSMA PET.
Yeah, not only PSA 0.1, we won't label as a recurrence. Okay, so
Yeah.
less than
Yes.
one. Less than one.
Sorry. Less than one,
So,
sorry.
okay, so PSA is increasing, but if you do a CT scan, obviously you won't see anything if a PSA is less than one. A bone scan, you won't see anything. But if you want to see anything and you are strongly suspecting there's a recurrence, then we have to go for a PSMA PET. That's a one situation you can use a PSMA PET. But the other situation, high risk prostate cancer, where you are doing a bone scan, looks negative, a CT scan looks negative, but before going for a curative intensive surgery, but you strongly think there must be some micrometastasis. So then in that case, high risk prostate cancer, in a staging, you can use a PSMA PET. So read around the PSMA PET. So it's a recent thing, expensive thing, but it's useful. So PSMA PET is very useful in high risk diseases.
Gobi, I think
Yeah.
few more things for the PSMA. You can add the for the CRPC progression also. You can use the PSMA PET. That's a added advantage because the more de-differentiated the prostate cancer is, higher the expression of PSMA membrane protein. So
Okay. Yeah.
So that's another advantage. Just to add.
Yes. Thank you. So that's about the PSMA PET. Then the next thing, I think we have discussed this, the details, different ways of visualizing the bladder tumor. What we use is a white light, but other methods are narrowband imaging and photodynamics diagnosis. The well popular photodynamics is a blue light. They ask about these things. What is the chemical we use? ALA or HAL. Then they ask about porphyrin metabolism. So is it protein porphyrinuria is contraindicated? You can't use that. So you give it in the bladder, and after a few hours, when you use the blue light, the tumors will be red, right? So they might ask you what is the basis of using photodynamic diagnosis, how it works. So you will see early cancers clearly. So you won't miss any cancers. So residual tumor will be less and recurrence will be less. But we don't know whether it's improved the survival. Up to now, there's no, of course, recurrence-free survival. Recurrence are less, residual tumors are less, but it's not proven to be increase the overall survival. So that's we have to know. They might ask how you get the blue light and what lamp they use. So they use a xenon lamp. There's a filter they use, a blue filter. So that's and the cable also, light cable also slightly different. they use a gel cable, but yeah, just know these words, how they, the difference. They prepare the chemical and give into the bladder, and this different filter and the cable. Just remember, if you don't know, it's fine. So tumors will be red. Tumors will be red when you use the blue light. Right. So that's Then the other point I want to say is the variant histology. We all know about the common histology. Just remember, they might ask what are the high risk histology in bladder cancer. The micropapillary, small cell, and a sarcomatoid. Let's use a few words, right? So they are high risk cancer. They are at the presentation itself most of the time highest risk, variant histology. Then the risk stratification of bladder tumor. Just remember these two words. URTC4, that's a commonly we use for a risk stratification of non-muscle invasive bladder cancer. Other one is a QTO. So this must be in the EAU. This is in the EAU guideline. So risk of recurrence decided by these factors. Risk of progression. So this EORTC, just remember, go and read around that because they can ask. So recurrence is mainly depending on number of tumors patient had. Multifocal, more recurrence. Other most important thing is the previous recurrence. These are the two things. Progression, more important things are gradings and the staging, TA or T1 or concomitant CA. So these 3 points, just remember. What is the difference between URTC and QTO is? QTO is similar thing, but previously BCG given patients. Okay, that's different. So risk group analysis, and you all know about the highest risk. You know about low, intermediate, high, but highest risk. Better to go for a upfront radical cystectomy. We are talking about non-muscle invasive. Highest risk. Who are the highest risk? G3T1 plus CIS, variant histology, and lymphovascular invasion is plus, and large or multiple G3T1. So this you have to know. Highest risk. With the highest risk, upfront radical cystectomy. Upfront radical cystectomy. Then they will ask about BCG. What is the problem? That there's a crisis of getting BCG all over the world. They had before, but I don't know about now. But now we have a problem in Sri Lanka sometime. So BCG is a live attenuated powder from the bovine bacteria. And so what brand we commonly use, and that things they will ask. Okay. Then how is ACT? Of course, they will ask. It's basically induce the immunity of other adjacent cells. They kill the cancer cells. And they might ask you about the regime. So we give 6-week installation. And what are the advice you will give to the patient after giving BCG? They have to keep it for 2 hours and things. They will ask these things, right? What are the advice you will give? So you give 6 inductions, then about 2 months of gap or 6 weeks of gap. Then do a check cystoscopy, all clear. Then another 3 installations. So that is maintenance. So there are different criteria, but protocols. But just remember few protocols. What they give. Induction and maintenance. Maintenance duration is usually 1 year. If you go for 2 years, it will be more complication. And you know the contraindication of BCG. I'm not going to talk about it. Right. Then pseudopouch, neobladder. They can ask how you create, whether it's a refluxing or non-refluxing. Usually it's a non-refluxing. Refluxing. So here they attach here. What is the length of the ileum? 60 centimeter and you bend 45 centimeters, those things they will ask. So 20 centimeter here, 20 centimeter there, 20 centimeter for this arm. So about 60 centimeter. So shoulder pouch and any other pouch. And I have already told you how different way of vellus and breaker, advantage of vellus, advantage of breaker, they will ask. They ask me, how will you, when you are making a neobladder, what are the measurements you take? And what is the law you will apply, Laplace law, and they will ask those things, right? And the other question today was regarding ablation. So again, this very popular ablation. So hot ablation, cold ablation. Cryo is a cold ablation, and HIFU or microwave or RFA, all those are hot ablation. So positive, negatives regarding the small renal mass, which is better, those things we have already discussed. That is given in the FRC's Viva book. So please read about it. This is becoming a bit popular, this HIFU, especially in the UCL, University of London Hospital. There's a big professor is doing this thing, HIFU. Just remember, this is a high frequency focused ultrasound scan that can use to burn the small prostate cancer. So his name is what? I can't remember. Yeah, Hasim Ahmad. So it's just that's one of the micro presentation I did during the FRCS course. But remember, there are so many methods to ablate the cancer. Then other than that, mechanism of action of solifenacine, mirabegron. I told you solifenacine act in the as antimuscarinic in M2 and M3 receptors. Mirabegron is agonist, adrenergic agonist. Mirabegron is contraindication when the blood pressure is more than 180, high blood pressure. But mirabegron advantage is not having any dementia problem or anticholinergic side effects. And we discuss about the action of Botox, and we discuss the action of sildenafil, tadalafil, and different advantage of different PDE5 inhibitors. Those we discussed already. And mitomycin color, it's blue, and how much they give, when you not to give. If you suspect a perforation, don't give, because it can cause fibrosis and can cause reaction. So those things we all discuss, I think. Yeah, any question, Dr. Nishant, anything else you want to add here?
Kobe, I think somebody has, I think Nalin has asked about CPEX. Can you just give a small brief account on CPEX?
Yeah, again, this is a topic I can't remember, but actually I can't remember the exact figures here, thresholds. So please, but that's yes, in pre-op assessment. Anyone you know that you can talk about. I can't remember the exact figures about the CPEX. But again, that was a micro presentation. That was popular micro presentation that the candidates do before the exam. Yeah. Anyone if I have a presentation, I can send you. But anyone know about it? You can elaborate on.
I just know just a few things, that it's just a sort of a what we do is basically we measure the carbon dioxide partial pressures and the oxygen partial pressures. We do it as a face mask ventilation, and then we ask the patient to do the exercise by an exercise bike or by a walking or a running a strip, and then we measure all these parameters of the oxygen parameters, as well as the cardiac monitoring, which includes the 12-lead cardiac monitoring. And then what I think what we need as the number is the anaerobic threshold. which is, I think the critical number is 11. I can't remember the exact units, but if you get less anaerobic threshold, your performance is, I think, less. So, but we need to read around it. There might be some more important things to add.
Yeah, it's one of the important topic. I can remember this is available in the sports medicine Sri Lanka cricket. It's recently the who is that cricketer Karnaratna, isn't it? He was doing it, and then our Prasanna Chaturanga Pranasinghe was posting the Facebook. So it is available here also. CPEX anaerobic threshold. Yeah, read around that.
Yeah, I think less than 8 is a severe cardiac problem. I think they are in the severe low performance scale. If it is less than 8.
Yeah. So it's CPEX. Anything else? Anyone else you want to give the input regarding those topics? Be confident. You all can do it, but as I said, just show them that you are confident, and don't react to the face expression. They will be like a a mask face, so you have to just proceed. Yes, we have to show our colors, and don't worry. It's just like after eating the rice, like eating ice cream. So it's a luxury thing we are having. So not to worry whether we are passing or fail. Yeah, sir, over to you, sir.
Gobi,
Yes.
a timing of investigation like MCUG after a PU valve, if you suspect, when would you do? And after a pyelonephritic episode, when would you do a DMSA timing?
Yeah, regarding the infection, Daha, so after pyelonephritis, you will have a transient ischemic scars, at least for 6 weeks to 6 weeks. So we will do a DMSA after 6 weeks, but they recommend at least about 3 months or 3 to 6 months. So no, there are no hard and fast rule, but you will get a transient ischemic scar in the kidney, which lasts for a minimum of 6 weeks. So never do a DMSA soon after the infection. So you have to wait at least about 3 months and do it. That is regarding DMSA and the pyelonephritis. The next question you ask is
MCUG for PUV.
now, if you suspect, even in the newborn, if you suspect the PUV, you have to do it early as possible. But of course, they won't do it because they put the catheter. Now, another question I want to ask, as you have asked, is in the PUV, in a newborn, what do you put as a catheter?
Feeding tube, 6 French feeding tube.
Yeah. Why not size 8 catheter?
Because it is more flexible. So because sometimes.
Just
Dr. Nishanda, yeah.
Yeah, I think the bulb just going to occlude the
Yeah, so when you inflate the balloon, even a small volume, that will block the ureteric orifice. That's why we are not using the catheter. We just put the feeding tube and we will anchor it. That's the question they ask. And they asked me one more question. After hypospadias repair, you put catheter and you put 2 napkins, is it? Anyone, one napkins, you keep the feeding tube into the between 2 napkins for diapers. So they asked, yeah, Dr. Nishana, yeah. So they asked me that question, how many diapers you put after, doing hypospadias repair, and where you keep the feeding tube, because you can't connect to the bag. So they kept between the 2 diapers, I think. So that's why they do it. I have never done this. So they asked that question, but I know the answer. That was a common question they asked in the mock vivas. So hypospadias, different types of hypospadias, different repair methods. So Snodgrass and things, just remember. And common complications like dehiscence, fistulas. Yeah, we know the basics. So read around. They won't ask hi-fi thing, but they will ask just to see whether we have seen at least few surgeries. Yeah.
Thank you, Gobi. You all must know a little bit of, I think, trauma also. No, Gobi. They must
Yes, sir.
read, yeah, renal, bladder, and urethral trauma. That you all can read. Guidelines are there, I think. It's easy. Okay,
Especially
thank you
the
very much.
grade 4 injuries of the kidney
Hmm.
and the urethral injury, what you will do. And the new terminologies are there when you have a prostate, the prostate neck apex separate from the urethra. Now they are not calling as a distraction defect. They use a different name. So, but just remember on the urethral injuries, and of course, urethric injury staging, grade 1. All those are given in the FRCS Viva book. If you know the section in the FRCS Viva book, the trauma part, those question and answers, that's more than enough.
Yeah, that's right. Better to read it well and be thorough with it. Shall we wind up then, Gobi?
Yes, sir.
Yeah, I think we have done enough. Go through the lecture again, slides of Gobi's, as well as the topics that I have sent. Read around it and be prepared. We will be having 2 more Uromet sessions in the coming weekends. So join and listen to those things as well, and I'm sure you all can do it. It's not going to be a big
The next
problem.
one is tomorrow, sir. Tomorrow.
Yeah, that's right. Yes. So thank you very much, everyone. Good night.
Good night.
Thank you. Thank you very much.
Thank you, sir.
Good night.